Gestational trophoblastic disease includes both benign and malignant proliferations of placental cells. At the benign end of the spectrum, there's moles. And no, we're not talking about the cute little brown ones above the upper lip. In this case, moles refer to a molar pregnancy. And they're also called hydatidiform moles. At the malignant end, there's invasive moles, which derive from the benign moles, and choriocarcinoma, which is a placental cancer that most frequently occurs in the absence of a molar pregnancy. Risk factors for molar pregnancies include maternal age extremes, like younger than 20 or older than 35, and a previous molar pregnancy. Moles result from errors in normal fertilization. Normally, at fertilization, a single egg with 23 chromosomes fuses with a single sperm with 23 chromosomes, resulting in a new organism with 46 chromosomes. This can go wrong in two ways, so we have two kinds of moles: complete or classic, and incomplete or partial moles. Both lead to an abnormal proliferation of placental cells and an abnormal placenta. The difference is that a complete mole appears when a chromosomally empty egg fuses with a normal sperm, and the sperm's genetic material duplicates to form a 46 chromosome organism. However, this organism doesn't have both maternal and paternal chromosomes, so the mole develops into a mass rather than developing into a fetus. An incomplete mole, on the other hand, appears when a normal egg is fertilized by two sperms, which forms an organism with 69 chromosomes that usually develops into non-viable fetal parts. With a complete mole, the placenta secretes a huge amount of HCG, so affected females present with signs of pregnancy, like missed periods and a positive urine pregnancy test. Vaginal bleeding is another sign, which may range from light spotting to heavy bleeding, and parts of the mole may even be eliminated, and they look like grapes or cherry-like clusters. Additionally, this huge amount of HCG leads to hyperemesis gravidarum, which is extreme nausea and vomiting and can lead to severe dehydration. Interestingly, HCG has a subunit that's similar to TSH, FSH, and LH. This causes symptoms of hyperthyroidism, like insomnia, anxiety, tachycardia, and palpitations, as well as the formation of thecal lutein cysts on the ovaries, which can cause adnexal mass symptoms like pain or pressure on the affected side. Finally, since the mole grows much faster than a normal pregnancy would, a physical examination shows a uterus that's too big for gestational age. An incomplete mole also secretes more HCG than normal, but not quite as much as a complete mole. So while missed periods and vaginal bleeding may be present, the uterus is not larger than expected for gestational age, and there aren't symptoms of HCG hyperstimulation like hyperemesis gravidarum, hyperthyroidism, or ovarian cysts. Most incomplete moles result in spontaneous abortions during the late first or early second trimester, and the diagnosis is made based on the examination of uterine evacuation contents. Okay, now with both complete and incomplete moles, an HCG level higher than 100,000 milli-international units per milliliter is diagnostic of a molar pregnancy. Sometimes, however, the HCG levels may not reach that threshold, so it can also be diagnosed when a transvaginal ultrasound shows a snowstorm or Swiss cheese pattern. This is a diffuse echogenic pattern resulting from the presence of abnormal placental villi and blood clots. With complete moles, thecal lutein cysts may be found on one or both ovaries, and with incomplete moles, fetal parts may be visible, and there's often oligohydramnios. Both complete and incomplete moles are premalignant conditions that can develop into invasive moles. Invasive moles tend to metastasize to the lungs, so a chest X-ray should be part of the workup. If hyperthyroid symptoms are present, serum TSH will be low and serum free T4 will be high. So the mainstay of treatment for both complete and incomplete moles is uterine evacuation, and this is typically done through suction curettage under anesthesia. Prophylactic uterotonic medication, like oxytocin, is given along with anesthesia to prevent hemorrhage after evacuation. Suction curettage per se involves three main steps. First, the cervix is mechanically dilated, and then the uterine contents are suctioned out, and finally curettage is done to scrape any remaining tissue from the uterine walls. The uterine evacuation contents should always be examined histologically for a definitive diagnosis. After uterine evacuation, it's important to get follow-up serial HCG levels to ensure that the pre-malignant cells are gone. The typical approach is to measure serum HCG weekly until it's undetectable for 3 consecutive weeks, and then once a month for 6 months. This should be done while the female is on reliable contraception, like the barrier method or oral contraception. If HCG levels rise or plateau, there may be a persistent invasive mole, or there may be a choriocarcinoma. Both of these malignant tumors arise from the abnormal proliferation of trophoblast cells. The difference is that with invasive moles, the chorionic villi become edematous, whereas with choriocarcinoma, the chorionic villi are not edematous. Also, an invasive mole always follows a molar pregnancy, whereas choriocarcinoma can also develop after a non-molar pregnancy, meaning a normal or ectopic pregnancy, or an abortion done for other reasons. A persistent invasive mole is more common after a complete mole, especially when the mole caused the uterus to enlarge, when the serum HCG level was over 100,000 milli-international units per milliliter, or where there are theca lutein cysts on the ovaries. The diagnosis is made when HCG levels plateau, meaning they remain within 10% of the previous result over a 3-week period, or when HCG levels increase more than 10% across 3 values recorded over 2 weeks, or when there is still detectable serum HCG up to 6 months after evacuation of a molar pregnancy. Choriocarcinoma accounts for a minority of the cases of gestational trophoblastic neoplasia that follow a molar pregnancy, but the diagnosis is the same. It's identified when HCG levels plateau or rise. An ultrasound should be done to rule out pregnancy, even if the female is on reliable contraception. On ultrasound, an invasive mole looks like one or more poorly defined masses in the uterus with anechoic areas, which invade into the myometrium. And on Doppler ultrasound, an invasive mole has anechoic areas with high vascular flow. On the other hand, on ultrasound, choriocarcinoma looks like a single mass distending the uterus. And it looks heterogeneous because it has areas of necrosis and hemorrhage. And on Doppler ultrasound, a choriocarcinoma also has high vascular flow. One unique situation is when a choriocarcinoma develops in the first year after a non-molar pregnancy. In this case, it may be trickier to diagnose because the serum HCG is not routinely being measured. So, these females often develop symptoms like abnormal uterine bleeding or unexplained amenorrhea weeks to months after a pregnancy. Secondly, there may be signs of excess HCG production, like hyperthyroidism or ovarian theca lutein cysts. And third, there may be lower abdominal pain or pressure because of uterine and ovarian enlargement. And finally, since choriocarcinoma is aggressive, there may be metastatic disease to the lungs, which causes coughing, dyspnea, or hemoptysis, or metastatic disease to the brain, which causes headache, dizziness, nausea, slurred speech, visual disturbances, neuropathy, and hemiparesis. Rarely, a metastatic nodule will develop in the vagina, and these are usually highly vascular lesions that should not be biopsied, because it can cause significant bleeding. When choriocarcinoma is suspected following a non-molar pregnancy, serum HCG values should be determined, and they're usually going to be really high. Additionally, an ultrasound should be done to rule out pregnancy and identify the tumor. The workup for both a persistent mole and choriocarcinoma includes a chest X-ray and a head, abdomen, and pelvic CT to look for metastases and to stage the tumor. Stage 1 tumors are confined to the uterus and there are no metastases. Stage 2 tumors extend to the fallopian tubes, the ovaries, or the vagina. Stage 3 tumors have lung metastases regardless of genital structure involvement. And finally, Stage 4 tumors have metastases in any organs other than the lungs or the genital structures. After staging, a risk score is calculated in order to select a chemotherapy regimen. The risk score is based on variables like age, previous pregnancy, time since last pregnancy, and pretreatment serum HCG, so a baseline value should be determined before treatment is initiated. Tumor-related variables include the size of the largest tumor, site and number of metastases, as well as whether or not prior chemotherapy regimens have failed. Each of these variables is scored from 0 to 4, and a total score is calculated. A score between 0 and 6 suggests a low risk of resistance to single-agent chemotherapy, whereas a score above 6 predicts a high risk of resistance and requires combination chemotherapy. For females with low-risk gestational trophoblastic neoplasia, a single chemotherapy agent is usually used. Options include methotrexate and actinomycin D, and usually methotrexate is preferred because it's effective, cheap, and well tolerated. In addition, methotrexate doesn't cause hair loss like actinomycin D can. However, methotrexate can cause medullary toxicity, so it's often given with folinic acid on alternating days. For example, if an 8-day regimen is used, methotrexate is given on days 1, 3, 5, and 7, and folinic acid on days 2, 4, 6, and 8. For females with high-risk gestational trophoblastic neoplasia, combination chemotherapy is recommended, and the preferred regimen is EMA-CO. EMA stands for etoposide, methotrexate, and actinomycin D, and CO for cyclophosphamide and vincristine, respectively. The O for vincristine is given because it refers to the brand name of that medication, Oncovin. The dash between the two means that they're given alternatively, so 1 week the female will receive 2 days of EMA chemotherapy, and the next week she'll get 1 day of CO, and so on and so forth. Additionally, for high-risk gestational trophoblastic neoplasia, surgery may be needed to resect sites of chemotherapy-resistant disease, or to control complications like bleeding or infection. During treatment, serum HCG should be checked weekly, and remission is defined as 3 consecutive undetectable levels. After achieving remission, 3 more courses of the last effective regimen should be given as consolidation therapy to reduce the risk of relapse. After consolidation therapy, the individual should use reliable contraception, and serum HCG should be checked monthly until monitoring shows 1 year of normal HCG levels. To end on a cheery note, almost all females with low-risk disease and most females with stage 2, 3, and even 4 high-risk disease achieve a complete cure. Alright, as a quick recap, benign gestational trophoblastic disease includes complete and partial moles. In both cases, the HCG can be above 100,000 milli-international units per milliliter, which is diagnostic of a molar pregnancy. In cases where the HCG level is a bit lower, a transvaginal ultrasound can be done, which shows a snowstorm or Swiss cheese pattern. With complete moles, fecal lutein cysts may be found on one or both ovaries. With incomplete moles, fetal parts may be visible on an ultrasound. Treatment is uterine evacuation through dilation, suction, and curettage. Follow-up includes getting the female on reliable contraception and measuring serum HCG weekly until it's undetectable for 3 consecutive weeks, and then monthly for 6 more months. Gestational trophoblastic neoplasia includes persistent moles and choriocarcinoma, and may be suspected if HCG levels rise or plateau following a molar pregnancy. Choriocarcinoma can also be suspected following a non-molar pregnancy. With both invasive moles and choriocarcinoma, no matter the context, serum HCG levels are usually very high, and an ultrasound should be done to rule out a normal or ectopic pregnancy. Further workup includes a chest X-ray and a head, abdomen, and pelvic CT to stage the tumor and calculate a risk score. A score between 0 and 6 means low risk, so treatment relies on a single chemotherapeutic agent like methotrexate. A score higher than 6 means high risk, and combination chemotherapy regimen like EMA-CO. Remission is defined as 3 consecutive undetectable HCG levels during weekly monitoring. And after remission, 3 more courses of chemotherapy are given as consolidation therapy to reduce the risk of relapse. After consolidation therapy, Serum HCG should be measured monthly, while the female is on reliable contraception, until monitoring shows 1 year of normal HCG levels.